Proximal junctional kyphosis and proximal junctional failure is a spectrum of disorders which happens following instrumentation of a long deformity, and especially in osteoporotic spine. I mean, basically it's a transition between a fused and the mobile motion segment. You can have a PJK and DJK. The PJK is much more commoner. Incidence varies in the literature, and the need for revision varies in the literature. PJK, as you all know, is a radiological phenomenon, whereas PJF is basically a clinical entity. And irrespective of whatever you do, the outcomes are relatively poorer, and osteoporosis is a significant risk factor. Therefore, PJK is basically a radiological phenomenon. It's basically a kyphotic change that happens between the upper instrumented vertebra and 2 vertebrae above. An angle of change of greater than 10 degrees. Literature varies with the angle between 5 to 20 degrees. Some people say 20 degrees is important because that's the area of where you can get a clinical symptoms. But basically, for all practical reasons, 10 degrees is what is taken. Whereas PGF is a progressive form of the spectrum where there is a failure, where it could be in the form of a fracture, it could be in the form of a soft tissue failure, in the form of implant failure and the need for revision surgery and neurological deficit. The various synonyms, the toppling off syndrome, proximal junctional failure, or proximal junctional acute collapse that has been used for this. Radiographically, you can have 3 types as brought about by Yagi et al. Into ligamentous, osseous, or the implant failure type. And based on that, the Bawaji et al. Classification, whereas the severity of it varies as per the degree of angulation, varying from 10 to 20 degrees to 20 to 30 and 30 degrees and above, and the presence of a spondylolisthesis. Recently, there has been one more classification system which probably guides the need for revision surgery, which I am not going to talk to you about. But we have to know what are the risk factors. Therefore, we can also get to the idea of what are the preventive factors. Risk factors, as mentioned earlier, age, elderly age, they are more likely to be sarcopenic, they are more likely to be osteoporotic. And when the BMD is less than 3.5, that there is a higher chances of developing the PJK. And this is now moved from, by using BMD, like Arvind uses QCT, but the disadvantage is the fact is that serial monitoring becomes difficult, and QCT becomes much more difficult when you are doing in the spine with the relation to ossifications, whereas the BMD gives you advantage of doing in other areas. But however, you can also use CT scan if you have used it for it, because the cutoff of the Hounsfield units varies when you take the lumbar spine, thoracolumbar, and the thoracic spine. Therefore, it moves from 100 to 120 to 147 in the upper thoracic vertebra. Therefore, it helps you to identify where to fix your instrumentation levels also. Coming to the radiographic related, it's basically depends upon the sagittal balance. The preoperative sagittal balance and the amount of correction what you do also has got a significant impact on the incidence of PJK. Surgery related, the approach, the posterior approach, the combined approach is much more common. The disruption of the posterior tension band. The fixed segments you use only pedicle screw at the upper end of the construct, the chance of PJK is higher. The stiffer the rod, the higher the chances of PJK. This is important for us to know what are the risk factors. Therefore, it helps us to approach the same way by looking at the prevention factors in terms of patient-related, radiological, and the surgically related. Patient-related exercise, even though it's said is not a practical solution, what is important is anti-osteoporosis treatment, as mentioned by my previous speakers. Teriparatide improves the Hounsfield unit by about 22%. And it's important that whenever you start teriparatide, whenever it's possible, it's better to delay the surgery for at least 3 months. Then also the data, what you get by low Hounsfield units, you can avoid by using a vertebra which has got less than 150 Hounsfield units, especially as you're going into the upper thoracic spine, and using a vertebra which has got a better Hounsfield units as the end point of your fixation points. And this is the paper published by Yagi et al. In 2016, where they showed that after 2 years of teriparatide treatment, this basically for long segment deformity surgery, there is a incident, the incidence of PJK decreases, whereas the advantage is the fact that PJF is significantly decreased in these type of patients, and the need for revision surgery is significantly lesser. Coming to the radiological factors, the incidence of PJF, actually the PJK came into prominence only when people started getting the alignment goals of having a PI equals LL plus 1 or minus 9. And then people realize that the age appropriate alignment goals are essential. Don't try to correct the deformity trying to get an alignment goal in all these patients. And it has been shown by Dennis et al. That the sitting balance is different from the standing balance. Therefore, it's important that when you are doing a deformity surgery as suggested by Gautam, try to align to the whatever the degree of correction you're going to get by patient positioning. Unless there is acute angulation, don't try to correct the deformity significantly more. Coming to the surgical approaches, probably the most important one, the prevention of damage to the posterior ligamentous structures. It's very, very important the upper part of the PLC is maintained. There is less damage to the facet joint. And you can use cement augmentation, the terminal rod into kyphosis. This is what majority of the surgeons do advise. Get the terminal, the upper end of the construct into kyphosis. Put the proximal screws into the anatomical direction, that is from superior to inferior, multiple fixation points. The selection of UIVs still remains controversial. Basically, using pedicle screws in the top is supposed to, not the pedicle screws, the hooks at the top, which is engaging the transverse process is better. It avoids injury to the facet joints in the PLC, less rigid the construct, and lower incidence of PJK. Of the various options, segment augmentation, multiple rods, marcelin tape, and sublaminar bands, cement augmentation still causes PJK, but of importance, if you're using cement augmentations, use only the upper end and +1, but not the all pedicle screws because the chances of pulmonary complications are higher. Sublaminar bands, as shown by this article by Vibhu Vishwanathan, that the chances of incidence of PJK significantly comes down. And you can use polyethylene tethers, but they are relatively much more expensive. And usually if you use the UIE and UIE +1, the chance of complications becomes lesser. And basically, as mentioned by Gautam, you contour the rod significantly. Don't try to pull on it. You allow it to sit. You can have additional amount of fixations. You can use the hook constructs whenever it's necessary. Therefore, a survey of deformity surgeons showed that what is important is terminal rod into kyphosis. Starting treatment, if the BMT is very low, use transverse process hooks at the top, plus or minus vertebroplasty, one level above and including the upper end of the fixations. To conclude, perioperative treatment of teriparatide is important because it helps you not only to increase the bone quality and also helps in the management of sarcopenia. Have good surgical principles, amount of fixation, the amount of correction you are going to do, damage to the soft tissue structures, preferable to have a soft landing. Thank you very much.